Moving on to mallet finger then. So here you're getting injury to the extensor digitorum longus, and it leads to a flexion or drooping at the fingertip of the DIP. You can see here there's that kind of droop that happens, classic of mallet finger. Can happen secondary to fingertip injury. So the classic is that you're catching a hard ball, playing cricket for example, and it can lead to a mallet finger. Most mallet fingers are treated conservatively, for example just using a splint to hold it back in place, but sometimes surgery is needed. And a few words on paronychia, so inflammation of the tissue folds surrounding the nail, so inflammation plus or minus infection, of course, and you can see a buildup of pus here, usually caused by Staphylococcus aureus if it's infected. And if you're looking at management according to the guidance, then moist, warm soaks may be all that's needed. There may be need for incision and drainage if there's a fluctuant pus collection or if an abscess is present. If someone doesn't need incision and drainage, or if someone has had incision and drainage and you're getting a question after this, then you're looking at 7 days antibiotics. So flucloxacillin or clarithromycin are recommended as per NICE-CKS. What are the rules for missed COCPs then? So it's something that very often comes up in this exam. So two things to look at really: how many pills have been missed and where in the cycle have they missed those pills? Which week of the 3-week pack usually have they missed that pill in? So let's start with just one pill first. Fairly straightforward. If they miss one pill, they retake it straight away. There's no extra protection needed going forward, and emergency contraception is not usually needed. So one pill generally is considered okay with COCP. The next bracket down is 2 to 7 pills. So if you get someone missing 2 to 7 pills, then what is the guidance for that? So you take the most recent pill there and then, so the most recent one pill there and then. You don't take, say, 3 if you've missed 3. Extra protection is needed until someone's had 7 consecutive pills going forward. So take the most recent pill, 7 days of extra protection. Now, the next bit of guidance depends on when they've missed those pills. So if someone's missed those pills in the first week, so they've got 3 packs that they're taking in a row, they've missed it in the first week, the first pack, they will need to think about the need for emergency contraception because they haven't had 7 previous days of taking the pill because they've had that pill-free break. So if it's in the first week, they will need to think about emergency contraception if there's a history of unprotected intercourse. If someone's missed it in the 3rd week, if they've missed 2 to 7 pills in the 3rd week of that pack, or the 3rd pack of that cycle, if you like, then you'd advise them not to have that pill-free break on that occasion. So they go straight into week 1 or pack 1 of the next cycle. They don't have that pill-free break. So it's really important to get those 2 caveats in place depending on when that person has missed 2 to 7 pills. And the third bracket down is if someone's missed 8 pills or more. If someone misses 8 pills or more, then there's no point trying to work things out. You basically restart as if you're starting the pill from scratch again and go back to all the original advice. And you'd be thinking, of course, about any other suitable methods that might be better for them. Maybe they didn't have them because of side effects, or they forgot, or whatever it might be. Let's look at acute otitis media then. Very common presentation, of course, so inflammation of the middle ear now. So different causes of that inflammation. It could be bacterial infection, things like Haemophilus influenza. It could be viral infections like RSV, for example. Lots of different things could lead to this inflammation of the middle ear. It's much more commoner in children. And there are lots of risk factors that you may again see in questions. Younger age group, like we mentioned, background of smoking, history of being formula fed, having a family history of otitis media, all these kind of things can increase the likelihood of it coming in the first place. How does it present? So classic ear symptoms, ear pain, but also systemic symptoms as well. Fever, someone may be very unwell. And if it's a younger child, for example, there may be a background of tugging or holding the ear. That might be the one clue to something like an otitis media. On examination, what might be described in a question, so red or yellow bulging tympanic membrane, you can see the kind of bulging nature when you look at the back of the ear. Sometimes there may be an air fluid level that you see behind the drum, and there may be a perforation of that eardrum that might be seen or described on examination as well. In terms of management, the usual course generally for otitis media is around 3 days, but it can take up to a week. So reassurance and advice generally. Analgesia, of course, if needed. There's no evidence of use of decongestants or antihistamines as per the NICE-CKS guidance if those are options in questions. So what does the guidance say in terms of management from a symptom control point of view? So for acute symptoms, like we mentioned, it's your GTN spray, take and stat, repeat at 5 minutes, 999 if no improvement. What about ongoing long-term prevention of symptoms then? First line is going to be either a beta blocker or a calcium channel blocker as per NICE-CKS. Beta blocker or calcium channel blocker. Second line, if you're winning, is monotherapy with one of four things. A long-acting nitrate, usually isosabide mononitrate is the commonest one, nicorandil, ivabradine, or ranolazine. So just remember these two, step 1 and step 2, in terms of symptom control for angina going forward. What about interventions that might take place in secondary care? So PTCA or CABG, so PTCA, percutaneous transluminal coronary angioplasty, essentially inflating a balloon to try and get rid of that blocked area, so the atheromatous obstruction. Or ultimately they might need a CABG, a coronary artery bypass graft, usually used in multi-vessel disease, usually used where a PTCA has failed, and a different vessel, so a vessel like an internal mammary artery, for example, is used to bypass the blocked areas leading up to the heart. So PTCA versus CABG in terms of interventional management. Lots of management options, as there is always with dermatology, and again depends on the area of the skin affected, but also the severity as well. So in primary care, community management, things like liberal moisturizers, liberal emollients are going to be the mainstay of a lot of different management plans for psoriasis. Vitamin D analogs, that's your calcipotriol, classically that you guys might have been seeing on a regular basis, and also topical steroids might all be used initially. Once it gets into secondary care, dermatology-based management, things like coal tar, things like phototherapy, your calcineurin inhibitors like tacrolimus and picrolimus, and also things like DMARDs like methotrexate, cyclosporin, and finally sometimes things like TNF alpha inhibitors, things like etanercept and things like infliximab as well. So lots of different options for a secondary care severe management plan when it comes to psoriasis, but generally moisturizers, emollients, vitamin D analogs, and topical steroids form the mainstay of treatment. So different scoring tools available for severity, but the one to remember for this exam, of course, is CRB65 or CURB65 if urea is present in a question, if you're getting some readings to try and work out a CRB65. So C relates to confusion, so an AMT of 8 or less would score 1 point. R relates to respiratory rate. If the respiratory rate is 30 breaths per minute or more, the person would get 1 point. B is for blood pressure, so your systolic or diastolic, both numbers are important. So if you have a systolic less than 90 or a diastolic less than 60, then that person would have 1 point. Often people look at systolic only and think it's an and thing, systolic and diastolic, but it's an or. So even if your diastolic is 55, but the systolic is normal, you'd get 1 point. And age, of course, is your 65. So if someone's age 65 or more with a community-acquired pneumonia, they would score 1 point. And like we mentioned, the U, which comes in CURB 65 here, is for urea. And the key number to remember is 7. A urea of 7 or more would score 1 point. So the benefit of doing a CRB score is twofold, really. It can help you determine where this patient should be managed. Is it in a community or hospital? And also what particular management is necessary for that patient. We'll come on to in a second. So let's look at the categories in terms of where should you manage a patient then. So a score of 0, the guidance NICE-CKS suggests home treatment should be considered because there's low risk of death. If the score creeps up between 1 and 2, then hospital admission should be considered because of the intermediate risk of death. And if score is 3 or more, then the guidance suggests that urgent admission should be advised because of high risk of death. So try and remember those numbers if you can. How is community-acquired pneumonia managed? Of course, it's different for different patients in different cases and different questions, but generally self-care management, things like rest, fluids, analgesia. Don't recommend cough syrups as per NICE-CKS in terms of management of pneumonia. The antibiotics, like we mentioned, are determined a little bit by the CRB score. So if you get someone with a CRB65 score of 0, then NICE-CKS currently suggests amoxicillin 500 milligrams 3 times a day for 5 days. And if someone has a penicillin allergy, then you're looking at doxycycline or clarithromycin or erythromycin. Let's spend a little bit of time talking about knee injuries then, in case it comes up in questions. Now, there are a couple of things you can look for in questions that can indicate the possible type or mechanism of injury. So let's try and go through a few of these that may help in questions. So we'll start with twisting or pivoting. If you see those words, then think about the possibility of menisci being injured as part of an answer. If you get a hyperextension explanation in the question, think about an anterior or a posterior cruciate injury. If you're getting the story of locking, of course, we've talked about osteochondritis dissecans as a condition that causes locking, but in terms of injury, think about meniscal injury or an anterior cruciate tear. If you're getting the words popping or tearing sensation in a question, think about meniscal injury or ligamental tear as well. If you get questions on knee swelling, look to see, is it rapid or is it a slower swelling? If it's a rapid knee swelling, it can suggest ligament rupture or patellar dislocation. If it's a slower knee swelling, then think about meniscal injury. But also, if you get a background of recurrent swelling, think about meniscal injury as well. And then you have your various tests. So you have, if you got a positive valgus or varus stress test where you kind of push the knee one side and the other, that can indicate a medial or lateral collateral ligament injury. And if you're getting a positive anterior or posterior draw test, when you've got their foot kind of flat with their knee bent, then it can indicate an anterior or posterior cruciate ligament injury. So there can be a few clues in the question as to the mechanism of what may be the underlying story behind knee pain following a knee injury. And when it comes to knee injury, the other decision is, do we need to do an x-ray or not? And this is where the Ottawa knee rules will come in. So you can think about the need for a knee x-ray if there are any of 5 features described in a question. Number 1, inability to weight bear for 4 steps, both at the time of injury and at consultation. Number 2, anyone aged over 55 with a knee injury, you might think about the need to do a knee x-ray. Number 3, isolated tenderness of the patella. Number 4, tenderness at the head of the fibula. And number 5, if there's an inability to flex the knee to 90 degrees. So if any of these 5 things are present in a question following a knee injury, think about the need to do a knee x-ray as part of your answer. So just like with autosomal dominant, there are a couple of scenarios and situations that are worth just going through in case they come up in an exam. And the first situation when it comes to autosomal recessive conditions is that one parent has a single affected gene. This parent is a carrier of the condition, but they don't have the condition themselves. There is a 0% chance the child will have a condition. There's a 50% chance the child will be a carrier. And there's a 50% chance the child will have nothing to do with the condition. So why is it 0% chance that the child will have the condition? Because there is no eventuality here when you go through all the different splits where a child has 2 affected genes. And remember, for an autosomal recessive condition, you need 2 affected genes. So there is 0% chance they have the condition. There is a 50% chance that they are a carrier. As you can see, there are two possibilities here where they end up with the one gene that's affected by that parent, and therefore they end up being a carrier just like their parent. And there is a 50% chance, these two here, that the child has nothing to do with the condition at all, i.e. they've not picked up that gene from the parent who was carrying it, they've picked up the 2 normal genes, and therefore they have nothing to do with the condition, not carrier status, or have the condition itself. That's scenario 1. Let's look at Barrett's esophagus then, often comes up in exam questions. So what is it? Metaplastic change of the underlying squamous mucosa. Now the dysplasia that happens can be low grade or it can be high grade, and the main cause of Barrett's esophagus is GORD or gastroesophageal reflux disease. So basically you're getting lots and lots of acid coming up as per GORD, and it's leading to this change in the mucosa itself. Now the Barrett's esophagus itself doesn't cause any symptoms, but because you're getting a lot of acid reflux, then the symptoms often link to those typical symptoms of things like dyspepsia or GORD itself. But Barrett's itself has no symptoms on its own. It's diagnosed at endoscopy, so you have to look at it and visualize it directly. And the reason it's so important is there's an increased risk of adenocarcinoma. So if someone has Barrett's esophagus, they'll need regular monitoring, for example, regular endoscopies, regular biopsies, and this will be on, of course, a case-by-case basis. But lots of management things that can be done, both from a primary care and a secondary care level. Lifestyle change, of course, reduce the things that are triggering things like GORD symptoms, like reducing smoking and reducing the medications that may be causing the symptoms, for example. Test and treat for H. pylori, and they may need long-term acid suppression treatment as well. Now, the management of the dysplasia can be different from person to person, and it might end up being that you need to take away that section, so mucosal resection. Someone might be okay with radiofrequency ablation, but some people might need the complete esophagus removing, so esophagectomy. So it does depend on a case-by-case basis. There's no one treatment fits all, but worth bearing in mind that some people with Barrett's esophagus may need an esophagectomy long term as an ultimate treatment. But what is the more longer term management of type 1 diabetes then, in case it comes up in questions? So some kind of structured education program is suggested, something like DAPHNE, dose adjustment for normal eating program. Lifestyle advice, like in all forms of diabetes, of course, insulin therapy is a mainstay of treatment. And when it comes to regular monitoring of BMs, remember in type 2 diabetes, there are certain types of situations where you would suggest the need to monitor BMs, but in type 1 diabetes, it is a standard thing that everyone should be doing at least 4 times a day, as per NICE-CTS, including before meals and before going to bed. But you'll need more frequent monitoring in certain situations as well. So if they're unwell, pregnancy, breastfeeding, before driving certain vehicles, and also if they've got a poor control history when it comes to diabetes. So regular monitoring of BM is very different to type 2 diabetes, and the target HbA1c though is still 48. So you'll be looking to get that target, that HbA1c down to 48 with all the changes that you might be doing from a management point of view. And usually this is checked every 3 to 6 months, but of course if it's poorly controlled, it may be much more frequent than that. So let's move on to insulin therapy then, of course, the mainstay of treatment for type 1 diabetes. There are currently 3 types of insulin in the UK. There are human insulins, there is human insulin analogs, and there are animal insulins. And this is used now, well, not very often compared to the other 2. And it's split into different things. So it can be split into different speeds of action. So you could have rapid or short onset acting drugs, or medium or long acting insulins. If you look at the rapid or the short acting insulins, things like Humalog, things like NovoRapid, things like Actrapid, these are a very quick onset and very short duration. If you look at the medium or longer term insulins, things like Humulin, things like Insulatard, things like Lantus or Levemir, these are slower onset but longer duration. So again, it's the balance of these 2 types of insulin that make up someone's individual insulin plan. And alongside the speeds of action comes 3 different types of insulin regime based on juggling around with the different types of insulin available and what suits that particular person best. So for example, the multiple daily injection basal bolus regime. So this is where you give different number of injections on different days based on what people eat and what people don't eat. So there's much greater flexibility in this program, and it's usually based around meal times. And because of the flexibility, it's first line generally in adults for type 1 diabetes. Secondly, so let's start this chapter off with potassium then, and we'll start with hyperkalemia or high potassium. So remember, a potassium of greater than 6.5 millimoles per liter needs urgent management. So if you see that figure in above, think about urgent admission. But one of the first things to think about in a raised potassium level is, could this be artifact? Could it be, for example, due to hemolysis? Therefore, do I need to repeat this potassium level? But that depends a little bit on how high it is. What are the key ECG changes that may well come in advanced hyperkalemia? Peak T wave, widened QRS complex, and a small P wave. And there are various conditions that may be in a question that show the underlying cause. So renal failure, Addison's disease, rhabdomyolysis, and things like metabolic acidosis as well. And there are certain medications to look out for in questions that, again, may lead to this hyperkalemia picture. Spironolactone, amiloride, ACE inhibitors, and things like non-steroidal anti-inflammatory drugs. Again, very common drugs that can lead to raised potassium levels. Why is it so important? Risk factors include things like cardiac arrhythmias, like VF, for example, and also ultimately things like cardiac arrest. And management will depend a little bit on the level of hyperkalemia, but it can range from things like calcium binding resins, insulin and glucose, sodium bicarbonate, and things like salbutamol as well. But once it gets to the point where it's treatment that's needed, then inpatient admission and these kind of methods may all be needed. And one of the point when we're talking about conjunctivitis then is ophthalmia neonatorum, something that comes up again in medical exams quite regularly. It's basically conjunctivitis which occurs within the first 4 weeks of life. And again, it can be infectious or non-infectious. But the key thing is within the first 4 weeks of life, think about ophthalmia neonatorum. Think of this being described if they talk about a sticky set of eyes, red eyes, of course. But again, the key thing is in the first 4 weeks of life, so in the neonatal stage. If you get a question that suggests this, it needs urgent ophthalmology assessment to have a proper review of the eyes. In most cases, ultimately are mild and will settle themselves, but they do need their ophthalmology input. If it's an infective cause, and the classic things we think about, things like gonorrhea or chlamydia, for example, then if we leave it untreated, it can lead to sight loss. And that's why it's really important to get an ophthalmology review very early on if you suspect that a question is talking about ophthalmia neonatorum.